Well, thank you very much. Good morning, everyone. And I want to thank you also, Leslie and Marjorie, for inviting me to be part of this event. I wanted to talk about something that is not as common as some of the other topics that we have heard today, and that's about standards and about standards around privacy. While we have a lot of standards, and that's the good thing about standards, there's a lot of them to pick, and we have a lot of standards around policies and a lot of things about how to exchange health information. The actual standards about the privacy, and particularly the privacy consent area, are less clear. And when you turn into electronic standards for collecting and communicating and executing consent choices, directives, preferences, however we call them, we're even in more dicey territory. So that's what I'm going to try to talk about. Over the last 4 years, one of the jobs that I had was to chair the Security, Privacy, and Infrastructure Technical Committee of the Health Information Technology Standards Panel, HITSP, which was created to look at the various standards around electronic health information exchanges for clinical information, for the most part. Administrative transactions were taken care of by HIPAA and other groups. And so we were looking at how to harmonize, how to take all the variety of standards that exist, standards in terms of vocabularies and content and format and communication and transport and privacy and security, and try to harmonize them into, this is the selected one for this particular application, and then present that as a recommendation to the Secretary of Health and Human Services for the Secretary to, first of all, accept them, and a year later recognize them. And by recognizing them, incorporate them into all the federal contracts, in reality, that the federal government holds with private and other entities, and through that, mainstream them basically as the required standard. So one of those sets is the privacy standards for collecting and exchanging and executing patient consent. And that standard is now officially accepted and has been officially recognized by the Secretary to be used. How much is being used is a question, and we'll talk about it a little bit more about it. But that's the frame of my talk. I want to also just try to give you some more scoping around the topic, because we could go along a lot of different directions. I'm going to be talking again about electronic standards for privacy, not so much security. We'll certainly have to mention some of that, of course. I'm going to talk about also another difference. One thing is internally how organizations handle privacy and security. And many of our organizations, Kaiser is one example, Intermountain Healthcare here in Utah, and Mayo Clinic in Minnesota, some of these organizations have NSA security level specialists that deal with the security of their internal systems. And I know of systems internally that are more protected than the Department of Homeland Security in reality. And so there is a lot of expertise and technology embedded into the organizations. Of course, in the spectrum of organizations, there are many healthcare organizations that don't have that technical capability, and then also don't have the level of security that others have. And we're talking about the same information, health information about consumers. So there is a big disparity around that. But I'm going to be talking about not inside an organization, but as an exchange, interoperable standards between organizations, and again, focusing on privacy standards and electronic exchanges. A lot of it is applicable to not just EHRs, but also PHRs, and more importantly, HAES, this evolving health information exchanges. This really, again, applies to primarily the ability to capture, to exchange, and execute these privacy consents and authorization. So just to draw a parallel, I'm going to be talking about more around this area, the consent side, the privacy side, the preferences, directives. the what and the why we are trying to, restrict access and things like that of our health information. I'm not going to talk about too much this area, security. There's a lot of activities going on around that. We do have a new set of adopted standards based on the recently published interim final rule on standards and certification criteria around a lot of these elements. So we already have standards defined in broad terms, not at the technical specific, application level, but in broad terms we have standards defined and certification criteria, meaning EHRs must be capable of doing a lot of these things so that the data is protected. I'm going to talk again about this side of the equation. Well, some of the principles, I don't necessarily need to go through a lot of this, but it's important to always remember, of course, that technology doesn't drive policy. Policy drives technology. But technology does inform policy. And when policy is going in different directions or in one direction, technology can offer some of the perspectives about the practicality, the cost, the ability to actually implement some of those ideas around policy and help define, okay, well, part of the policy is not just how we're going to do this, but how much it's going to cost us and whether it's feasible to be done. Now, technologists will say anything is feasible. We can build anything if we have all the resources and money to do it, but certainly they can bring in some of that perspective. Now, with respect to privacy, in the absence of a single standard national policy around privacy, which we don't have in this country, well, technology has to move along and try to develop and establish some standards and offer them and implement them in the systems that organizations use. And those offerings, those options have to be flexible enough to accommodate, to adapt to the various policy alternatives, which makes the technology a lot more expensive because now that capability has to handle many different options, many different regulations, laws, and in one state, a particular product of a vendor doesn't have to do this, but in another state, it has to, so the vendor has to build it and then have it available. And some places they can turn it on, and some places they can turn it off. And then lastly, policy should not really constrain technology advances, but rather give the direction, the overall goal. This is what we want to see happen. How it happens, that's part of the technology, but really the policy should not be constraining the possibility of advances in technology. And that's why it's very hard to encode in regulations that you shall use this particular encryption algorithm or a particular integrity digital signature technology to protect the data or to exchange the data. Because when you go that direction, well, you're establishing a technical definition in a regulation that then prevents new advances in technology, because everybody's going to say, well, that's the standard, we have to use that, we don't need to do that, or we don't need to change that. So that's why it's very difficult and challenging for regulators to try to come up with solutions or technology. And when you're talking about privacy and security, or when you're talking about security specifically, either you tell me what's the encryption algorithm I have to use, or you just can't tell me I have to use encryption, which is what the regulations tend to say. So that's part of the challenge. Lots of new terminology. We started with simple terms like consent and authorization, but we're now into these other terms that you started to hear, maybe have heard in some time. Consent directives and consumer privacy preferences. These new, relatively newer terms really reflect sort of the changing world in which we are with respect to health information. This is not anymore the traditional, I'm in a clinic and I'm the doctor and I have the record and that's it. Now there's PHRs out there and the patient has the record too in different ways, and there's these exchanges that are allowing people to exchange data. And so really the consumer now has a lot more controls and capabilities to protect their health information by providing directives and providing expressing preferences, and we'll talk in some more detail about those, of course. Now, very quickly, you all are very familiar with this idea that certainly healthcare is not a very easy system, it's a very complex system, but from a perspective of what we do in terms of defining standards for technical standards for security and privacy, it has a lot of complexities. It has many actors, you know, from the patient to the provider, health plan, employer, government, all these different actors that play into the collection and exchange of information. It has many different types of information, demographics, financial, clinical, and in many different forms, digital images, text records, codified information, and many different processes related to health information. There's the collection, the creation, maintenance, modification, access, use, disclosure. Different purposes for which information is being captured, and very important pieces of information when we deal with privacy choices. Many different places where this information is being collected and maintained. And there's a lack of a number of important standards, like we talked about yesterday, common identifiers, particularly the patient identifier. Then there's many different laws. We all are very familiar with that. There's federal laws, state laws. There's even different policies. I remember in Minnesota, when I lived there, we used to have, I mean, Minnesota had one of the most stringent privacy, health information privacy laws in the country. It requires actually consent for everything. Doesn't matter if it's treatment, payment, operations. HIPAA doesn't need, you know, says you don't need to, but in Minnesota you do. And so we as providers had to collect consents from patients when we needed to exchange the medical record for a referral to another provider. Internally within an organization, no, because that's not a disclosure, it's a use as it's defined in HIPAA. But for disclosing information on a referral to another provider for treatment, we had to obtain a consent. Well, some organizations in Minnesota had policies that were even more stringent than that. And so there's different levels, not only the federal and state laws, but policies that organizations choose to establish that are more stringent in the sense of more protective, of course, not less protective than the federal law, because of the state law, because they have to follow those. And then there's all these increasing complexities. Now, of course, information is in electronic systems. We see a lot of more electronic communications between patients and the systems through websites, emails, moving information in many different ways, from the, you know, just email attachments to DVDs, to CDs, USBs, you know, smart cards, and all sorts of different technologies. The expanded use of electronic health record and personal health records, the development and you know, expansion, I guess, of the health information exchanges, regional as well as this nationwide health information network. And then now also electronic mobile devices that are transmitting information. I'm presenting to the Telecommunication Industry Association in a couple of weeks about cell phones and other smartphones, and the ability of them to do patient consent and patient preference as well. I can now communicate, code and communicate that, and what kind of standards have to, the machine itself needs to support in order to allow that to happen. Not just exchanging the actual data, because in the future you also need that, but of course the protection, the encryption, all those mechanisms in the mobile devices will be there, but it's specific about the consent part. So a lot of these complexities are making us you know, be much more aware of the need to expand on all these consumer choices about privacy. So what is happening with privacy in terms of consent and on authorizations today? Well, many of you are, of course, very experienced about that as consumers, as patients. You go to a clinic, and for the most part today we still use, if you are in a state that requires so, or for whatever particular purpose, you're still doing paper forms. You're still, you know, providing a consent or an authorization via paper form. And then usually a general consent and authorization information release kind of authorization, and then additional consent or authorizations are used for specific type of disclosures when it's required. There is no standard paper form across the country for a patient consent or patient authorization. And there are only some states, so each organization has its own form, but some states are beginning to have one. Minnesota is one of the states that established one reference form. This is not the official, you have to use this form, but this is a reference form that organizations should use, a standard reference form developed by the Department of Health in Minnesota and published in their website, and they have it available and people can download. And organizations in Minnesota now have a reference point. Say, okay, now we can use this as a reference. Now, with the world moving to EHRs, of course, the EHRs also started to accommodate for all this. I was at HIMSS earlier this week, and I went around, the 3 miles of worth of exhibits, walking around this exhibit show, and I asked about 10 different vendors of EHR products that were eager to sell me their products as soon as I say Kaiser Permanente, of course. Yeah. And I'd ask you, well, I only have one question for you. How do you handle patient privacy, and how can a consumer in your system, process their consent? And so they start talking about all sorts of, security and encryption, and we do those. And I said, no. I just specifically, show me the screen, or show me how you, when I am a patient coming to a clinic that uses this system, how would the consumer or patient, be? Oh, and they say, oh, okay, no, well, we do have a little screen here that allows the consumer to read this. And so that's the kind of application that EHRs are specifically including now, sort of screens or forms in the EHR tool that provides for different types of consent, because they say, well, we have informed consent, of course, the consent to be treated in this facility. We have the release of information authorization, which allows my client, my clinic client, to bill and send the claims and bill, for payment purposes. And then we have all these other authorizations of other disclosures. But then they jump into saying quickly, well, we also have some special protected information. And they said, we do flag some data in the record that is sensitive. And so I started saying, so how do you classify sensitive? Who decides what's sensitive? And they started to go down some dicey roads around that. But in reality, they do have. Most of the EHR systems, of course, have the ability to flag and to selectively make sure that some data that is sensitive in the eyes of the product developer, but also customized for the specific application, they can be identified and handled in a different way. And then the consumer signature is also captured. In fact, some of them have actually very simple digital paths, that, like the ones you go to a shopping center or grocery store and sign in here when you're checking out, or the general consumer acknowledgement form. So those are the ways in which currently EHRs are capturing that. Here's one example actually of a screen where a consumer can allow or disallow, and they can pull, I can't pull it out actually here from the screen, but they can pull this menu down and then identify certain types of information to be accessed, or depending on disclosed, accessed, viewed, by whom, and then for what purpose. So these are sort of the 4 key parameters, and then you can see here, I disallow this restricted mental health to be accessed by administrators, and then I allow some restricted data to be accessed by direct care providers for treatment. So you can create this type of tools around your electronic health information that help internally define what can be accessed. PHRs and HAES, there's also work around that. The PHRs, of course, have shifted a lot, and this is the vendor-provided PHR, so this is the Health Vaults and the Google Health of the world. They do have, of course, a lot of more consumer controls of their information. Here's a screenshot of our Health Vault privacy principle. You control the Microsoft Health Vault record you create. You decide what goes into your record. You decide what can be seen or not. They do have these, user agreements, or they agree to terms. Click here and you agree, and you don't read that because it's 15 pages, 10 font size, and you just agree. And then they do have some other authorization capabilities. The HIEs, the health information exchanges, the way they are evolving is much more around allowing consumers to, consumers allowing providers and other entities to exchange information via the HIE. So it's the famous opt-in or opt-out. In fact, in some states, actually, they have adopted state laws that require the HIEs to offer or offer the consumers to opt-in or opt-out, depending on which one. Most states are using the general opt-in. Now, the interesting thing is the general opt-in here means basically it's an all or nothing kind of a acceptance. It's not, I am going to accept an opt-in for certain data, like in the third option, which is not used at the moment, as far as I can tell, in most of these HIEs. Opt-in with specific restrictions, meaning I can, you can send via the HIE my demographics and some of my medication, but the medication, I don't want this particular drug to go in there. So that kind of restrictions is not done in the HIEs. But that's a new level of consumer choice that exists, the HIE option. So what's the new paradigm here? Well, is to offer consumers and the healthcare industry an interoperable, meaning ability to exchange outside of my organization with disparate systems, standard-based electronic mechanisms to collect, capture, maintain, report, transfer, exchange, and execute consumer consent directives and preferences in a manner that allows users to meet different types of jurisdictional requirements. That's the ultimate goal. It's a very tough one to make, but it's really the direction in which all this is going. What are some of the characteristics of a good set of standards? I'm not going to go in detail into this, but these are some of the characteristics that one expects the standards to have. Be consumer-friendly, a consumer-friendly mechanism, not be a very convoluted set of choices that the consumer has trouble even understanding and certainly making a choice. Scalable, codifiable, basically meaning being able to be expressed in standard codes. Machine readable and executable, because that's what we want, automate some of these processes to allow this to be machine executed. Portable and interoperable, of course, very flexible and adaptable, supporting different jurisdictions. Be verifiable and auditable. So there could be a tracking mechanism to ensure that changes done to the policies or the choices made by the consumer can be maintained. And then complete and unambiguous, basically making sure that if a consumer makes changes later on, there's a way to reconcile and ensure that the most accurate, latest version of the preferences are being made. So we're moving really from the traditional simple concept of consent and authorization to a much more complex consent management system that involves all these different things, consumer privacy preferences, the actual selections and choices that the consumer make, converted into consumer directives inside the organization. Once we accept the preference as an organization, it becomes a directive in our organization. And then executed through access control policies, very strong, tight access control policy. All that is wrapped around this consumer or consent management process. What is our definition of consumer privacy preferences? Interestingly enough, before HISP ended its initial 4-year work in late January, ONC, the Office of National Coordinator, provided us with a use case of consumer preferences. And we were to develop the recommended harmonized standards. We worked through some of that detail. What the definition was consumer preferences was the expression of choices and desires defining access restrictions to their health information. And access here consider both uses and disclosure, not just the disclosures part. What were some of the considerations? and these are some of the more challenging things. All these are the key 7 or so, 1, 2, 3, 4, 5, 6 key elements. The what is the information that the consumer can control? All, some, certain, by whom? Which is the entity that will be doing the disclosure or the access, allowing the access to happen? To whom? So who is the entity, which is the entity that will access or will receive the data? For what purpose will be this allowed? When? There will be a time factor restricting that. And then how? There's the method, the opt-in into an HIE. Yeah, I will allow this data to go through an HIE or not, depending on the choice. So what I'm getting into in here is the big question of granularity. You know, to what degree can a system and a policy ultimately define the choices and preferences that consumers can have? Can a consumer say, I want this particular data element, you know, a particular drug, to be disclosed by this particular provider to this particular provider for this particular purpose within certain time frame and by some mechanism? That kind of a granularity today is pretty impossible to handle. Most systems, and we'll talk about the standards, handle much less granular level of detail. So here's the multiplicity of options I just explained. You know, the highest level is a simple opt-in, opt-out. You know, I opt in and you can disclose anything you want to anyone for whatever purpose. Or you can do certain data for certain purpose, to certain people, those kind of things. Policy certainly affects those permutations. For example, in the United States, we have some laws that require that lab results, and this is being changed actually. There's a new, recently, just earlier this week, some change in that. Laboratories are required to report the results only to the ordering provider. So that's a restriction. I can only disclose it to this provider. So I'm done. We don't have any more choices. Technology costs, of course, grow exponentially with the greater level of granularity controls, and ultimately major patient safety risks and quality of care. And I do have to step back for a moment and point to all of you that we're really doing this for trying to improve the care of consumers. And we have to balance very carefully, you know, to what extent privacy and the, extent to which we can provide detailed level of protections on privacy and options on privacy will actually hamper and even create patient safety risks, because the consumer might be choosing a lot of things that might not have good knowledge and understanding about necessarily on the confusing process, and then a provider will not have access to the right information at the right time to care for the patient. So there is that important risk. Okay, with consent management, there are several functions, and I'm not going to get into the detail here, but there's, of course, the capture function, the maintenance, the cross-validation, the exchange, the execution, and the audit. All those are critical consent management functions that are being embedded into these standards. And this is the more technical graph I'm going to show. I'm going to not show any other one, but in the realm of things, the concept is basically, because we're talking about interoperability, we're talking about connections through things like HIEs. There's two conditions, primarily, two underlying conditions. One is you have to have a preference repository, a place where all these preferences are maintained, so that actually consumers can go and see them, providers and others can see them. Those preferences, they don't have to be in a central national repository bank of consumer preferences. They can be distributed in a federated model through different mechanisms, but there has to be a place where these preferences sit. And then the other one is there has to be a management service that processes and handles all this codification and access to that, so that an electronic health record, someone outside here wants to see the record, the electronic health record can go and check for the preference of that access and decide whether it will allow or not to have that be accessed. A number of national, and so where are we with the standards? Do we have standards? The answer is yes, we do have. In fact, as I mentioned earlier, we have an accepted and recognized standard by the Secretary at this point. Who have developed this standard? Well, international standard bodies and national bodies have been working for a number of years to do this. And many of you might be familiar with some of these terms. Some of you might be, this is the first time you see this. International, there's the first organization I'm listing is called IHTIQ. It's called the Integrating the Healthcare Enterprise. I'll talk about each of these in a minute. HL7, a national, international organization defining standards also. ASTM, ISO, and HISBIA. Those are the core ones. There's a few others that are doing some work around this, but these are the core ones. So IHTIQ is a worldwide consortium of vendors, electronic health record vendors and healthcare organizations that develop this new, how many of you have heard about BPPC before you came here? One or two, couple of people. BPPC stands for Basic Patient Privacy Consent. It's a international standard profile to allow, and it is the most widely recognized standard profile for capturing and sharing privacy preferences within what we in the technical world call an affinity domain, which is another term to say within a HIE or a, or organized system of organizations that want to exchange data between them. What does this BPPC do? That's basically three things. Records the patient consent in a standard policy codifiable way, mark the standards, mark the documents or tag the documents with that particular consent choice, and then allows the enforcement of the privacy consent. Those are the three things that this standard does. How does it work? Well, technically, and I'm going to try to avoid getting into a lot of the technical details, but technically, basically what it does, BPPC uses something called the OIDs, object identifiers. In the interoperability world, those are critical codifications. It's almost like your IP address, if you will. It's very unique. It's a unique thing that points to a specific thing. There's not two or three equal to that. There's just one. And it has a reference place that says, well, if you are looking for this whole string of characters, this is what that means. So it uses OIDs. And what happens is the affinity domain, this HIE, says these are all the various policies that we are going to use and allow, in this case, the consent policies, because there's not just policies around privacy and consent, there's policies around all sorts of things. But the consent policies are defined within the affinity domain within this HIE. And then organizations in that affinity, in that HIE structure or exchange, offer those consent policies to the consumer. The consumer make the choice, and then those get transferred into the affinity domain, and then they get tagged. That string of numbers get tagged to the documents that are part of that decision of the consumer. What's important about it is that the document now has a way to say this document, which is about a consumer, the consumer has said the following about it with respect to consent. And the reference metadata of OIDs in that affinity domain provide the reference for what is the meaning of that particular tag in that document. So everybody knows about it and understand it in a standard way. Now, a couple of limitations, I guess. One is, this is at the document level. So you cannot tag data elements. You cannot tag age, gender, at this point. I mean, technically at some level we will be able to, but the extent and the complexity of it will be such that it will be more difficult and impossible, almost impossible to handle that. So at this point we're tagging documents. Now, in the electronic health record world, the most common standard document when we're talking about, if you're talking about my medical record, it's this thick, folder of paper documents. In the electronic health record is called CDA, basically one of the most common standards, the clinical document architecture developed by HL7. And there's a couple of references on that, I guess. But the general content, the concept is the electronic version of your paper record is a CDA, and that CDA then gets tagged with this particular OID. That's how it works. This standard. There's many different types of policies that can be supported. The opt-in level of policy or opt-out, all the way to selecting this document to be shared or not. I'm not going to go into the details of these particular choices. And there's a number of other features. The patient acknowledgement of each of the preferences can be captured electronically through the actual signature can be scanned too, or it supports digital signature. It also supports tagging of what we call unstructured documents, like a PDF or an EKG can be also tagged with this type of OIDs. And then it supports various topologies, various types of exchanges, including my documents in a USB. So that document now has a tag, and then the tag transfers in or converts into a particular policy. All right, very briefly to finish up some of the other standards. HL7 has also developed a number of standards. They concentrate primarily on what is called the reference information model for the version 3.0, the next version of their standards. There's also work being done by there's a security work group and what would be a privacy work group working on a domain analysis model, basically defining how the privacy and security will be done within a HL7 document. They also define the code sets, many of the code sets used as a reference for consumer preferences, like confidentiality code, the level of confidentiality, defining in 15 or 16 different codes, different levels of confidentiality, or the health permission catalog, a catalog of permissions of what can be done by entities when accessing a document, view, delete, modify, this kind of option. ASTM, the American Society for Testing and Materials, have also developed a number of codes. Codes that related to the purpose of use, actually, that's one of the areas they work on. So they classify the actual different types of purpose of use. And this is now being adopted as the standard and the international standard reference for purpose of use on health information. ISO has a committee, I was actually meeting with them on Saturday, developing the different types of codes that reference the classification of providers, of provider organizations. This is a physician and nurse, and this kind of, as well as the roles that they play. And there's differences in the roles, you know, from the type of provider. So a physician can be caregiver, or it can be a consultant of different types of categories of roles. And then finally, HITSP, the Health Information Technology Standard Panel. We developed two products. One is called Transaction Package 30, or HITSP TP30, Managed Consent Directives. This document basically, again, our role was to harmonize all these standards from HL7 and ASTM and ISO. So we created a package that an organization can use to implement electronic consumer preferences. And we translated that into something we call the Capability 143. So these two documents go one hand in hand. And so those are some of the things that HITSP has done. All these documents are publicly available on our website, hitsp.org. And they have been accepted and recognized by the Secretary of Health as the national standards at this point. Now, they were not adopted in the IFR, the regulation, and I'll mention in a few minutes some things about it just to finish up. The other concept around this is the certification of products, EHR products, specifically to privacy. One of the other roles I play is chair the privacy work group of CCHIT, the Certification Commission on Health Information Technology, that developed the certification criteria for an EHR to meet with respect to privacy. There's a different group dealing with security, a different group dealing with other things. These are some of the examples of the criteria that we started to do for the ambulatory EHR product. We have a different one for, well, you know, this applies also to inpatient products. But so we have already a set of criteria embedded in the certification process. Now, of course, many of you have heard that on Tuesday of this week, ONC published the certification process notice of proposed rule, which basically calls for, we're going to have a temporary process, and we're going to designate someone to do the temporary certification so that we quickly can do this meaningful use thing. Expect to see CCHIT probably in that role, but don't quote me on that. And then the permanent process, which will be a much more complex process that involves an accreditation of certifiers, and then many certifying entities. Once could be CCHIT. But in the meantime, this CCHIT has done a lot of work around certification. One interesting thing you might not have realized is that in the IFR for standards and certification criteria, and in the NPRM, there was no mentioning whatsoever of privacy. There was only one mentioning that I'll point out. So in the IFR, there were 6 standards named for security, access control and encryption and integrity and secure communication, things like that. There were 10 certification criteria on security, but none on privacy. There was nothing about, now, I'm being too harsh about this too, but the reality is there were some possible things that could have been done about including some certification expectations on EHR products. You know, the EHR product will be capable of supporting consent preferences. Simple one. But anyway, that's one reality that we have today. The one mentioning is the NPRM meaningful use, where it says there was no specific mentioning on the privacy itself, but you can see at the bottom there's this health outcome, policy priority called ensure adequate privacy and security protections. But when you look at the actual measure for stage 1, is conduct a review of risk analysis and implement security updates. So it's not really anything about privacy. Of course, trying to measure the meaningful use of an EHR for privacy could be a little bit challenging, but it could be potentially done. And so that's one specific opportunity that we have into the future. My last 2 slides. Challenges related to interoperability standards. Of course, there's a lack of portability of consumer preferences across jurisdictions. Portability means basically, if I'm in Minnesota the law says I have to get consent, so I give my consent, but I live actually in Wisconsin, so sometimes I go to the Wisconsin doctor, they send a request to Minnesota. Minnesota doctor says, well, I have to have the consent of the patient. Well, I'll give him consent. So he sends that data to Wisconsin. All right, now my data from Minnesota, which are well protected in Wisconsin, there's no law that requires consent, so that provider can disclose it to anyone. So the exact same data exercised in 2 different, and I express my choice of consent or not disclosing in one state is not portable across jurisdiction. There's a whole segmentation of data. We'll hear more about that, of course, in the next session. Automating the minimum necessary access issue. That's another interesting area. A lot of new things around minimum necessary. A lot of new things coming out around that. How do we automate that control and access? That's a pretty challenging one. Electronic digital signatures to support patient preferences is still at work. The electronic concept of break the glass. Interestingly enough, that was one of the questions I had in HIMSS, and they showed me the screens that the doctor can say, I need to break the glass. So click here, it will show a screen, and then I'm breaking the glass, but be aware that the system will keep a log and note that you are breaking the glass, and you need to codify what the purpose of breaking the glass is and all that. But there's a lot more to be done around that. Mobile technology I mentioned is an important one. Differences between EHRs and PHRs with respect to these privacy preferences. And the biggest, the holy grail of all, I guess, is the granularity issue of consumer preferences and controls. That's at the bottom. So the take-home messages. First of all, standards do exist to electronically capture, maintain, exchange, and execute privacy, consent, and preferences. They have been acknowledged, accepted, and recognized by the Secretary. They are in place in many electronic health record systems. Code sets already exist also to classify types of data, levels of sensitivity, roles and users, and purpose of use. Are they the perfect code sets? No. They were developed by people that had some understanding, of course, of some of the regulations and laws and regulations, but they were thinking more of the technology side. But they had to because the product needed to have something, and they couldn't wait until we had a national standard, unique way of establishing, purpose of use or sensitivity level. Given the multiplicity of privacy policy standards must be flexible to accommodate these different requirements, electronic health record systems incorporate patient consent features that can be customized to specific jurisdictions, and that's the reality today. But much more needs to be defined in terms, of course, of policy to allow privacy standards to move to the next level of functionality and specificity. So with that, I'm going to turn back and thank you.